Hello, everyone. My name is Alan Towne, and as you can see, I'm at Virginia Commonwealth University, which is in Richmond, Virginia, and also I'm National Director of the Epilepsy Centers of Excellence. So I will be talking a little bit about military TBI also. I'd like to thank the Anita Kaufman Foundation and the Purple Day organizers for inviting me to this presentation. So post-traumatic epilepsy, and I've many times we'll call it PTE, but it's post-traumatic epilepsy. It remains a leading cause of neurological disability and death in the United States and in around the world, really, developed and developing nations. There are approximately 2.5 million TBI ED visits, emergency department visits, 282,000 TBI-related hospitalizations, and 56,000 TBI-related deaths. This is just for 1 year. And among the survivors of TBI, there's a sizable number that remain with important medical and neurological disabilities, sequelae, including seizures and epilepsy. Going a little bit into the history, Hippocrates is always somebody who first noted things. So Hippocrates did recognize that TBI had been associated with the development of epilepsy, but it really was under-recognized. And in the mid-1800s, a series of 67 patients was described by the French physician laureate. And he felt that a head injury was one reason to have epilepsy. The other thing was fear was the most common etiology in his series, and it was responsible for a little bit over half of his cases. So we know that not to be true now. Post-traumatic epilepsy is a disorder characterized by recurrent late seizures, and I'll mention that, what I mean by late seizure episodes, and it's not attributable to another obvious cause in patients with TBI. So there is a distinction to be made between post-traumatic epilepsy, which I mentioned before, are recurrent unprovoked seizures following a traumatic brain injury, and seizures that are seen immediately following a head injury. So many times right after the incident, you may see immediate seizures. So those are seizures by definition occurring less than 24 hours after the injury. And then you can have early seizures occurring between 24 hours and 7 days. And then the late seizures, and that's really what we're going to be focusing on. It is felt that the seizures occurring right after the event does not necessarily predispose to having epilepsy or recurrent seizures. So as I mentioned before, immediate and early seizures are believed to be the result of the acute injury and do not constitute epilepsy unless it recurs. Okay, so I'm not going to go over all the specific characteristics of each type of TBI. But TBI is defined as an alteration in brain function caused by an external force. Alteration of brain function is defined by one of the following clinical signs. Since we can't go in people's head and actually see what's going on, we defined TBI as any period of loss or decreased level of consciousness, or LOC. Any loss of memory for events immediately before or after the injury. So what we call post-traumatic amnesia. Neurological deficits, they can be various things. It can be weakness, they can be hemiplegia, they can be sensory loss, aphasia, and so forth. And any alteration in mental state at the time of the injury. So it can be confusion, disorientation, slowed thinking, etc. The difference between the different types of TBI really depends on the length of the alteration of consciousness, the length of post-traumatic amnesia, and we also will throw in there to make the classification if there are any type of abnormalities on imaging studies. So what we can see here, depending on the type of TBI, you can see that the probability of unprovoked seizures in patients with TBI increases dramatically in those patients with severe TBI. And we do see that depending on, as you go from mild TBI to moderate TBI to severe TBI, we will see that the incidence of epilepsy increases. Looking at the epidemiology of post-traumatic seizures or epilepsy, traumatic brain injuries account for about 20% of symptomatic structural epilepsy observed in the general population and 5% of all epilepsy. So TBI is a leading cause of epilepsy also in young adults. So what I mean symptomatic structural epilepsy is that there's something there that we know is causing it rather than a genetic type of epilepsy. So the overall incidence of post-traumatic epilepsy in hospitalized patients following a non-penetrating TBI is approximately 4 to 7%. And it depends on the type of injury and the patient also. Post-traumatic epilepsy will be observed in approximately 35 to 65% of patients with penetrating TBI. So we know, and we've known this for quite a while, that penetrating TBI is a cause of a significant amount of disability in patients, and many patients will exhibit seizures after a penetrating type TBI, which you can see in, let's say, in the battlefield. We can see after if you have a shrapnel or a wound that causes penetration of the dura. And then approximately 1/2 to 2/3 of patients who suffer post-traumatic epilepsy will experience seizure onset within the first 12 months, and 80% by the end of the second year following the injury. So we're going to see most of the patients, if after TBI, within the first year of having the injury, and in the second year you'll see 80%. So there'll be 20% that will actually have seizures after the second year period. So after 5 years, adults with mild TBI do not appear to have a significantly increased risk compared to the general population. But patients with moderate or severe TBI or penetrating TBI remain at an increased risk after this post-injury duration. And some of this information we have from the Vietnam head injury study, which reported a very late onset of post-traumatic epilepsy. And so what we see here is that even after 5 years, 10 years, 15, and greater than 15 years, the prevalence of post-traumatic epilepsy continued to increase. And this was from an article, a well-known, well-researched article in 2010. So as I mentioned before, the natural history is immediate post-traumatic seizures are generally believed to carry no increased risk of recurrence. On the other hand, between 1/5 to 1/3 of patients with late post-traumatic seizures or epilepsy will experience frequent recurrences. So the seizures may present with a variety of manifestations, depending on where they arise. As we know, most of the post-traumatic epilepsy, they're focal, and so depending on what part of the cortex they arise, there will be different manifestations. The other thing we have to worry about is in patients with traumatic brain injury is that they may have other symptoms, not necessarily related to the epilepsy, but related to the actual traumatic brain injury. And we know that patients even with mild TBI, but definitely patients with more severe traumatic brain injuries, they may exhibit cognitive, behavioral, or other affective sequelae that may mask the seizures. And so you may have you may have some patients who have suffered a TBI who have cognitive difficulties, and it may be difficult to actually find or determine if the cognitive difficulties are due to a seizure or are they due to the underlying traumatic brain injury. So what is the mechanism, simple mechanism of post-traumatic seizures or post-traumatic epilepsy? Well, it may be due to direct damage of the brain tissue. You can have shearing forces during TBI. You can have infarctions. You can have secondary irritation because there can be a hemorrhage after a TBI. They can also be triggered by secondary insults, such as patients who may have a traumatic brain injury and then suffer an anoxic event or hypoxic event. So looking at what we have been doing at the VA, and again, many of these things can be brought over to the civilian side, although obviously sometimes the TBIs, the mechanisms are a little bit different and the etiologies are different. But as you can see here, TBI in Iraq and Afghanistan, in the Iraqi and Afghanistani veterans is relatively significant. And this is from numerous studies that we've been tracking over the past 20 plus years. So when we look at DOD numbers for traumatic brain injury, what we see are most of them are mild TBI. And this is the same thing what we see in the civilian population. We have a cohort that are moderate, a little bit more have moderate. Severe is definitely much less, and penetrating is between the moderate and the severe. This was in 2014, 2000 to 2014. We are continuing with these studies, and we have actually in some of our databases, we have up to a million veterans that we're following with traumatic brain injury. Not all of them have epilepsy, but we are following these veterans on a regular basis, determine when or if they develop seizures. Leading causes of TBI. Now this is from civilian, falls, a major component. Motor vehicle accidents, assaults, unknown. What we see in the veteran population is that we see the same type of thing, but the other etiology that is significant is blast injury. And so we tend not to see blast injury except in a few cases where there are explosions and so forth in the civilian population, where in the civilians it's falls. In the military population, blast injury accounts for a significant number of TBI and epilepsy. So just to stay on the military side of things, some experts have estimated that the incidence of TBI among wounded service members to be as high as almost 23%. And DIVBIC, which is one of the organizations tracking TBI and epilepsy, we have a couple lead centers. One of them is in Richmond. We've treated thousands of OEF, Operation Enduring Freedom, Operation Iraqi Freedom patients with TBI. And so we are continuing to follow these veterans over the years to determine how many of these will develop epilepsy. These are a couple of the publications we've done. This was a 2015 one that we published looking at the prevalence of epilepsy in association with traumatic brain injury in veterans of the Afghan and Iraqi wars. That was in 2015. This one here is a newer one. It was published a year ago, and we were looking at understanding post-traumatic epilepsy to understand the relationships among a lifetime traumatic brain injury, history, epilepsy, and quality of life. Some of the quality of life measures I think you're going to hear in another lecture. by Dr. Canner, I believe. He's giving one. This is part of our publication in 2015. You don't need a, this is, you know, there's some epidemiological data here, but with mild traumatic brain injury, the risk of having epilepsy was 80% greater. When you look at moderate, it's 3 times greater than a population that did not have TBI. And if you look at severe, the risk of having epilepsy is 7 times greater than if you didn't have a TBI. And with penetrating, it's 21 times greater. So you can see as you go up the scale from mild, moderate, severe, and penetrating, the risk of having epilepsy increases significantly. So what we had found is that 53% of veterans who suffered a penetrating TBI in Vietnam developed epilepsy within 15 years. And I showed you that. This is just to reinforce what I had told you. And the relative risk for developing epilepsy more than 10 to 15 years after the injury was 25 times higher than veterans in the same age group. In fact, as you can see from the graphic, 15% did not manifest epilepsy until 5 or more years after their injury. So this is one reason why TBI and, of course, epilepsy centers have been established around the country. Now, we are part of the Epilepsy Centers of Excellence, which is in the VA system, but around the US, there are epilepsy centers that are obviously not non-VA. We have an epilepsy center at our institution at VCU, and many of the major institutions and the people you'll hear from during this presentation are part of they're part of institutions that do have centers of excellence that treat patients with epilepsy, and also many of the institutions will have TBI centers. And so it's very helpful. We found it's very helpful to combine the expertise of TBI experts along with epilepsy experts. I'm going to mention a little bit about blast injury because it is an important aspect of epilepsy in service members. Basically, you have a overpressurization, and then you have maybe projectiles from the overpressurization, and then you can have the individual, the soldier, thrown against an object, and then there can be burns and so forth. And so there's the mechanism of this makes it difficult to say what caused the epilepsy if there is TBI secondary to blast injury, because you have a couple different reasons that they could develop epilepsy, because there are multiple reasons that the brain can be involved. This is just showing a graphic where you have a blast wave, and then there can be a secondary blast injury if there's shrapnel or something like that, and then a tertiary one if you are thrown against an object, a tree or whatever. We do see the same type of thing in explosions in the civilian sector too, but it's much less prevalent. But we do see it. But there certainly were head injuries during the Madrid bombings and also in the Oklahoma City bombings that had the hallmarks of blast injury. I'm just showing you this one during one of my deployments. This was a blast injury caused by a vehicle-borne IED, and you can see the vehicle was actually blown up, and then our Humvee was there. I wasn't in the Humvee, but one of my colleagues was, and this is what the Humvee looked like. Fortunately, everyone lived. Obviously, they suffered a TBI, but the This was a reinforced Humvee, and it protects pretty well against certainly direct injuries of blast, but there's certainly the shock wave that goes through the whole vehicle. But these people lived and did pretty well. We do know that blast exposure can affect the brain, and it can look similar to those diseases such as Alzheimer's disease and Parkinson's disease, as well as ALS. So there is a significant, even if you're not thrown against an object, there's significant changes in the brain seen after a blast injury just due to the shock wave. Now, there is a overlap between TBI and PTSD and acute stress reaction. Dr. Canner, I think, is probably going to delve more deeply into this, but even within the civilian population, especially with motor vehicle accidents, I do see patients who have acute stress reaction and PTSD as a result of a motor vehicle accident. So we do know that sustaining any kind of physical injury is known to increase the risk for PTSD. And the other things are there are several symptoms that are found in both PTSD and mild TBI, such as attention deficits, memory, cognitive disabilities, irritability, sleep disturbances, etc. So even within the civilian population, there may be a component of a psychological component that may confound some of the symptoms that you may think are seizures, especially if they're focal seizures, and PTSD. And of course, we do know that TBI has its own set of difficulties, as I mentioned before, in terms of having psychological and psychosocial difficulties afterwards. So neurobehavioral symptoms associated with TBI, I'm not going to go over all of this because I think it's going to be covered elsewhere, but there can be impulse control, emotion and anxiety problems, cognition and memory difficulties, behavior, and somatic symptoms. These are very common, and they can be seen in mild TBI. Typically, fortunately, these neurobehavioral symptoms resolve typically within 6 months or a year, but occasionally they can become chronic. And especially if there is if the patient has had prior history of psychological or psychiatric difficulties. What are risk factors for late post-traumatic seizures or post-traumatic epilepsy? That's what we're talking about. Well, age, children have a lower risk of PTE. Alcohol use is associated with an increased risk of PTE. Family history, there probably are variables, genetic variables, and that's something we're also looking at that may increase the chances of patients having PTE. There are also some biochemical markers that have an increased risk of late PTE. One of them is the ApoE allele. Other characteristics, injury characteristics. Well, certainly, as I mentioned before, if you have intracranial involvement, that increases your risk significantly. Depressed skull fracture, increased injury severity increases your risk for PTE, focal contusions, focal hyperperfusion that you can see, especially if the blood vessels are involved or if there's a hemorrhage, and dural penetration. So I'm going to mention briefly, and again, I didn't see it in the agenda, but it may be covered, but PNES or psychogenic non-epileptic seizures. They're also often called pseudoseizures or psychogenic seizures, are terms used for episodic behavioral events which superficially resemble seizures, but are not associated with paroxysmal activity within the brain. So non-epileptic seizures, epileptic seizures may be psychogenic, but the other things you have to look for is in the differential is that they may look like other things that are non-epileptic, such as syncopal episodes, fainting episodes, cardiac attacks. And, it's not unusual to have PNES associated with patients who actually have epileptic seizures. Okay, so the differentiation between the two sometimes is very difficult to determine just based on the basis of clinical characteristics. And so in many of these cases, EEG monitoring, especially with video, is often helpful in establishing the diagnosis and probably is essential in establishing the diagnosis. Many of these patients we admit to our epilepsy monitoring unit so they can have video EEG, prolonged video EEG. This was a study that was done by one of our colleagues. This was comparing veterans and civilians admitted to the epilepsy monitoring unit. Psychogenic non-epileptic seizures were identified in 25% of veterans and 26% of civilians, so very similar. But that's still a lot. So you have 1/4 of patients who were admitted to the EMU who had PNES. Now, some of these, as I said before, had recorded electrographic seizures too, but a fair amount of these just had psychogenic non-epileptic seizures. 58% of veterans with PNES were thought to have seizures related to traumatic brain injury. In the veteran group, PNES was the single most common discharge diagnosis and more common than the discharge diagnosis of epilepsy. So they were admitted to the EMU for various different reasons. I mean, and some of these patients actually had syncopal episodes or non-epileptic type episodes that were not PNES, but PNES is very common. We also know that PTSD has been shown to be a significant risk factor for developing PNES. And again, as I said before, this can be seen both in the civilian population and in the veteran population. So the EEG provides valuable information for localization, for severity prognostication, and it may identify the presence of non-convulsive seizures. So these are seizures that you don't see any overt manifestation, especially in patients who present with episodes of impaired consciousness. So the utility of EEG in predicting post-traumatic epilepsy or post-traumatic seizures following a seizure-free period has not been established. We're looking, there may be some biomarkers. There's an ongoing study now that we're participating in, looking at various biomarkers. And the second stage of this study will be looking at electrographic markers to try to determine if we can predict the patients who may develop post-traumatic epilepsy after TBI. So as I mentioned before, it's useful if you can see it, if you actually capture abnormalities, but again, it can't prognosticate, and this is after Dan Lowenstein's work. So a normal EEG may precede post-traumatic epilepsy onset and felt to be a favorable prognosis. But you need to evaluate. EEG is just a tool in our armamentarium in diagnosing and properly treating epilepsy. So the utility of interictal EEG, so in between the seizures, is limited. It's in many of our traumatic brain injury patients, especially the more severe ones, the EEG is many times abnormal, but doesn't necessarily indicate that the patient is going to have seizures or not. It usually reflects the damage done by the TBI. Interictal activity can be seen in about 50% of single awake recordings in adults with epilepsy. Many times, if we include sleep, the yield is much greater. Also, the more recordings you do, two is better than one. This will increase your yield. The other thing is that if the routine EEGs or the sleep-deprived EEGs or multiple routine EEGs don't yield a diagnosis, we employ frequently ambulatory EEGs, which are 24 to 72 hours. The other thing is that we do have home EEG monitoring, and pretty much most of the epilepsy centers have either home monitoring, and the epilepsy centers do have long-term monitoring, which are epilepsy monitoring units. But sometimes that home monitoring is helpful because the patient is in their surroundings that they feel comfortable with, and sometimes we've found that may be more helpful than even in the hospital surroundings. So Ann Hudak, which is one of my collaborators in Richmond, described the utility of prolonged video EEG monitoring in the clinical management of paroxysmal behaviors in TBI survivors. I mean, so these survivors had different types of clinical manifestations, and the ambulatory EEG was very helpful in determining whether these things were actual seizures or whether they were other manifestations that were non-epileptic. Monitoring was conducted for an average of 4.6 days and was successful in establishing a diagnosis in over 80% of cases. 62% of the evaluated patients had focal seizures. Generalized, they were probably, with these 6%, probably focal with very quick spread. So it was difficult to know. It was difficult to see where the onset was, because it was probably very deep cortical propagation. And 33% had PNES. So management of post-traumatic epilepsy, well, basically establish the diagnosis. So the use of anti-seizure medications, about 33% of patients with a first unprovoked seizure can be expected to have a second within the subsequent 3 to 5 years. Of course, it's variable. As I mentioned before, depending on the severity of the TBI, the risk of having PTE increases as I showed you previously. Over 50% of patients with a first remote symptomatic seizure or lesional epilepsy will experience a second seizure in the next 3 to 5 years. And of the patients with a second seizure, almost 87%, almost 90% will experience a third seizure at 5 years. So the decision to start treatment in a patient with a first seizure, you got to look at the relapse versus the benefits and the consequences of having anti-seizure medication on. I mean, there are risks to it, and so it has to be individualized. The other thing that we individualize is also what agent we use. With post-traumatic epilepsy, the patient has at least one comorbidity. They have the TBI, and so there are some agents that we prefer not to use in patients with traumatic brain injury because it may cause increased irritability, and it may actually decrease their cognitive status. I'm not going to go into all the medications that we use, that's a lecture in and of itself. And I believe that there's another lecture that's going to be going over some of the medications that can be used for patients with seizures. But basically, when we look at it, is the response to anti-seizure medication. The first drug, many patients, 60% will be managed appropriately. Managed meaning they won't have seizures. Second drug, another 20%, and the third drug, less than 10%. And then additional drugs, there is less efficacy as you add drugs. That doesn't mean you shouldn't add drugs or you shouldn't add different medications. But again, most patients will see control during the first medication, and then an increasingly less favorable response as you add as you go up from the first drug to additional drugs. So about 20% of patients are refractory, meaning they continue to have seizures. Okay, I'm going to just show you this graph since there's another lecture that will go over these things. But really, when we're looking at the types of seizures and the medications, there's a lot to choose from. With post-traumatic seizures, we're looking at focal seizures, so either focal aware, focal impaired, or impaired consciousness, or evolution to convulsive tonic-clonic seizures. And as you can see, there's quite a bit of medications we can choose from. Other approaches, non-pharmacological approaches to the management of post-traumatic epilepsy, lifestyle modifications. There is going to be a lecture on ketogenic diet. There also going to be a lecture on the vagus nerve stimulation for seizures. I'm going to mention briefly cognitive behavioral therapy for PNES. We're currently piloting a program for PNES and with cognitive behavioral therapy. It's been around for a while. Dr. Kurt LaFrance up in Rhode Island has developed a cognitive behavioral therapy for psychogenic non-epileptic seizures that has been quite successful in alleviating these type of events. There are also surgical treatments I'll mention briefly, and then there are other new stimulation modalities. I mean, the vagus nerve stimulator has been around as a device, been around for the longest as a device. So surgical treatments can be very helpful in post-traumatic seizures. Basically, there's surgical excision of the seizure focus. Certainly is an important treatment option for certain patients with refractory PTE. We have seen seizure freedom in many of our patients after the resection of the surgical area. Other types of patients, such as with unilateral post-traumatic frontal lesions who undergo complete resection of perilesional encephalomalacia, respond particularly well to surgery. So if you actually can find the lesion that is causing the seizures, excision of that lesion can lead to a dramatic response and seizure decrease. VNS, I'm not going to mention because it's as I said before, it's going to be part of another lecture. This is what it looks like, but I'm sure the presenter will show you that. The RNS system is a responsive neuro system that is intracranially implanted. Over the area, we have to find the ictal area, and the device finds the seizure, detects the seizure, and stops the seizure. And you can query this device and actually find out how many times it is stimulated. So it's actually helpful to determine how many seizures the patient is having, because it may terminate the seizure before the patient can actually feel it. Okay, so a few take-home messages. The more severe the TBI, the more likely to develop epilepsy. I think I've shown you that. We don't really have a prophylactic treatment for PTE. There's nothing we have found that can prevent post-traumatic epilepsy. PTSD and PTE may coexist, and again, the diagnoses, it may make the diagnosis difficult, especially if somebody has both of these things, and trying to determine if the events, unusual events they may have, are actually due to seizures or they're due to the PTSD. And then we need to evaluate patients with intractable epilepsy with video EEG monitoring. So the gold standard for the diagnosis and treatment of intractable epilepsy, intractable PTE, is epilepsy monitoring. Okay, certain areas of research that we're looking at right now. We're looking at different type of neuroimaging techniques. As I mentioned before, we do have a ongoing study looking at possible genetic factors and biomarkers that may influence post-traumatic epilepsy. We have expanding databases looking at this. There are a couple large studies looking at it. One of them is the Limbic Sensi study, which we're part of. It was about a $50 million study to look at post-traumatic epilepsy and TBI. We need to look at long-term cognitive outcome and PTE. PNES I mentioned before. We're looking. We have some studies looking at the PNES prevalence and treatment of that, as I mentioned before. And what we'd really like to do is develop modalities to prevent the seizures from even happening, prevent PTE. And again, that's we haven't found that yet, but hopefully in the future we can. So I'd like to thank you for your attendance, and I hope that this has been useful.